Welcome everyone. My name is Marthinus Wolmarans. I'm a ComServe currently in ONG. I worked 3 months at Rahima in the ED there, and I also did 3 months of Pete Surge at the start of the year. So yeah, now I'll be doing a talk on hypothermia. Let's jump into it. So on the introduction, what is hypothermia? It's when the core temperature, which is measured by the esophageal, rectal, or bladder probe, is less than 35 degrees Celsius. The normal value ranges from 36.5 to 37.5. Core temperature arises from the balance between heat produced by the body and the heat lost to the surroundings. And there are 4 mechanisms that are responsible for the heat loss. These 4 are radiation, which is when the body emits electromagnetic energy to the surroundings. Conduction, which is when thermal energy transfers between objects in contact. Convection, when air molecules moving past, or when heat is lost with air molecules moving past the heated object. And then evaporation, which we see quite often, is when heat transforms liquid into a gas, as when the thermal energy from the skin vaporizes sweat. So you forgot your jacket, what now? Your hypothalamus is what regulates the body temp through autonomic mechanisms. Your brain receives input from central and peripheral thermal receptors. Muscle tone and your BMR will increase initially in response to the cold stress. Then heat production can double through these mechanisms. Shivering also enhances heat production, increasing your metabolism to 2 to 5 times the baseline BMR. And then important in the Rahima ED, newborns lack the shivering mechanisms due to an incomplete development of the nervous system. Thus, they use brown fat. Brown fats, just to go into it, is where the brown fat's thermogenin increases the mitochondrial membrane permeability and disrupts the electron transport chain. This disruption and subsequent hydrogen ion leakage blocks ATP production and then generates body heat. So what is the differential of a hypothermic patient? Obvious triggers like cold exposure, massive transfusion, dialysis, and surgery. Then the distributive shock we also see quite often, specifically sepsis. Metabolic causes like hypoglycemia and DKA, hypothyroidism, adrenal insufficiency, thiamine deficiency, malnutrition, and anorexia as well. Toxicologic causes like ethanol, sedatives, and opioids. Phenothiazines and tricyclic antidepressants, sympatholytics like beta and alpha blockers, central alpha agonists, carbon monoxide poisoning, and OPP, which we see quite a lot, as well as lithium toxicity, quite a host of things that can cause hypothermia, and then as well as neurological causes like spinal cord injury, MS, Parkinson's disease, and a thalamic injury as well. So the overview is shown here. I think the most important thing on this slide, we will go into the management later, is the Swiss staging system for hypothermia. And this classifies it into mild, moderate, severe, and then a pulseless patient. Mild being less than 35, moderate less than 32, severe less than 28, and pulseless less than 24. The presentation of hypothermia. In a mild hypothermic patient, you'll have an increased BMR. You will have maximal shivering of the patient. Patient can have amnesia, dysarthria, ataxia, and apathy as well. Patient at this stage will still have a normal blood pressure. So with moderate hypothermia being less than 32, progressive reduction in temperature will result in stupor. Shivering will stop. You can have AFib and other dysrhythmias, as well as your cardiac output will then be about 2/3 of normal. There's also progressive loss of consciousness, pulse, and respiration, as well as the pupils can be dilated at 29 degrees. With severe hypothermia, there's loss of reflexes and progressive paralysis. Reflexes will be absent at 26 degrees Celsius. You can get a major acid-base disturbance as well at this stage. Then significant reduction in cerebral blood flow as well. This will be about a third, as well as cardiac output being at about 45%. Pulmonary edema, significant hypertension, and bradycardia can develop as well at this stage. Your maximal risk for VFib will be at about 22 degrees Celsius, and then a flat EEG and asystole at 18. Slippery slope. Investigations that you will look at, always do a finger stick glucose when the patient comes in. You can do a FBC, which could help with sepsis as well, UEC, and ABG as well. It's important with the ABG to do the gas immediately after drawing the blood. You don't want to put the gas in your pocket, then the blood can heat up and you'll get a different picture as to the cold patient you have. Clotting studies as well, septic markers, thyroid function tests, and blood cultures, or a toxic screen if it is indicated. Then with regards to the imaging, this will be dictated by the clinical need. Some patients may have an inciting incident like trauma or a cerebrovascular event that lead to a significant body temperature drop. You can do a chest x-ray. If there's suspicion of trauma, bedside ultrasound can also be used to confirm cardiac activity and volume status. And then a CTP could also benefit individuals with altered mental status, which is not sort of linked to the hypothermic picture that you have. ECG is also important to do. The typical sequence is a sinus brady, then going into AFib with a slow ventricular response, then VFib, then you'll have asystole. Other ECG findings that are specific to hypothermic patients is an Osborne J wave. So the size of the wave correlates with the degree of the hypothermia, but this is not a prognostic value. This is no prognostic value. You can get a muscle tremor artifact as well, T wave inversions, PR, QRS, or QT prolongation, ST segment elevation or depression, AV block. You can get PVCs, as well as with hyperkalemia. It may not show the typical ECG changes associated with the elevated potassium levels. Here are the examples, so specifically how a J wave looks, muscle tremor artifacts, as well as ST segment elevation with the J wave present. Going into the management, always important to do ABCDE, and then sort of your management that's specific to a hypothermic patient. Of course, oxygen. Hypothermia causes a leftward shift of the oxyhemoglobin dissociation curve. You'll have to intubate if it is necessary, and remember with RSI, medications may act at a slower rate. IV analgesia and warmed IV fluid should also be given through two large bore IV cannula. Call for help, remove wet clothing and blankets, and cover with a bear hugger if you have a bear hugger, or warm blankets. Gentle handling of the patient. It's been said that rough handling can precipitate dysrhythmias, but there's minimal evidence. Now, rewarming the hypothermic patient with a pulse, and always do external warming. Warming blankets including a heated air system like a bear hugger. You can warm via the lungs as well. So the alveoli does have the largest surface area. So you can provide heated, humidified gas via nasal cannula or via CPAP. And then invasive methods is patient specific. So you'll have to look at the case in front of you. Of note, most patients with a pulse will respond to methods 1 and 2. IV fluids, important. Hypovolemic patient could be hypovolemic, since hypothermia causes impaired renal concentrating ability, which can cause cold diuresis. And these patients are prone to rhabdomyolysis as well and will need hydration. Normal saline is always preferred over Ringer's lactate, as a cold liver poorly metabolizes Ringer's. And then fluid warming ideally should be done in an inline warming device. Also, you can, if you don't have that, you can just put bags in microwave for about two minutes. The bag should feel comfortably warm, should not burn the patient. Also attempt to do a thoracic lavage. This heats the patient up at about 3 to 6 degrees Celsius per hour. How to do this? You put 2 chest tubes, one anterior, one lateral. Alternatively, you can put 2 chest tubes maybe placed in the lateral chest, one directed more anteriorly and one more posterior. It's most effective to perform this on both sides, so with 4 chest tubes in total. Then you infuse warmed crystalloid fluids into the anterior chest tube. You drain fluid from the chest by attaching the posterior tube to suction. And then remember, what goes in must come out as well. So measure what you put in and then measure what you've taken out. You can also just put a large bore chest tube in the lateral chest and then install 300 to 500 mils of warmed fluid, clamp, and then drain it out. With a bladder lavage, this is known to be less effective. There's 2 ways to achieve this. You can use a dedicated 3-way Foley catheter with continuous irrigation of warmed fluid, or you can just install 300 mils of warmed fluid, clamp it, and then drain it out later after about 15 minutes. Here are the rates of degrees Celsius per hour warming. Cardiac bypass ECMO has the most, 7 to 10. Hemodialysis is also quite high, 3 to 4. And then the rest are listed as well. Now, resuscitating the hypothermic pulseless patient. This could start pre-hospital. Rewarming, should start pre-hospital. Extended CPR should be performed. Hypothermic patients can have a good outcome despite hours of CPR, because hypothermia is neuroprotective. Modifications to the standard ACLS in hypothermia. Medications may fail to be metabolized and accumulate, so avoid repeated doses of medications. As the patient heats up, these medications will become active and could be an overdose. Defibrillation may also be unsuccessful until warmed. Thus, serial shocks for VTAC and VFib is unlikely to add benefit. As the patient rewarms, further attempts may be done. And then just in brackets, VA ECMO or cardiopulmonary bypass is the gold standard. It supports oxygen perfusion. The circuit warms the patient at about 7 to 10 degrees Celsius per hour, which is the highest rate that you can get. This is a study that was done at Steve Biko. I found it quite interesting. It looks at neonatal hypothermia, I think quite relevant to the ED setting. So the objective of the study was the incidence of and factors associated with hypothermia on admission to a neonatal unit at Steve Biko Academic Hospital. It was a retrospective cross-sectional study of infants admitted from September 2019 to Feb 2020. And the results showed an overall incidence of hypothermia on admission of 66%, mild 25%, and moderate to severe about 41%, with a mean admission temperature of 35.1. So infants remained hypothermic for a mean of 4.1 hours after the admission. Hypothermia was also associated with an increased risk of duration of respiratory support, an increased duration of respiratory support, about 3.2 in the hypothermic neonates, and about 1.7 days in the normal or in the non-hypothermic normothermic patients. And then it also showed a longer length of stay, quite significant, 17.9 days versus 10.9. This incident, the incidence of hypothermia on admission to the unit was quite high compared to other units. And for us, I think hypothermic infants take a significant length of time to regain normothermia. Everything in our power should be done to make them normothermic. So important points to remember: patients may present unconscious, pulseless, and with a lack of respiration. Resuscitation must be initiated right away in such individuals and should be continued until the patient is warmed. Most commercial thermometers can only read to a minimum of 34, and you'll need specific low reading thermometers to get in like an exact patient temperature. The esophageal thermometer is the most accurate way of determining a patient's temp. Coagulation tests may also be inaccurate unless the patient has been warmed. And then if a patient fails to rewarm despite appropriate rewarming techniques, underlying causes like hypoglycemia, infection, hypothyroidism, and adrenal insufficiency should always be investigated. And I think that is it.
Hi everyone, am I coming through? Can everyone hear me?
Yes.
Yeah.
Okay, perfect. Marthinus, thank you for the talk. I'm Francha. I'm the EM Reg. I see Kelsey's also asked a question here about gastric lavage. I think we'll get to that now. Just some feedback on the talk itself. I think it was really good. It's really nice. It's a fantastic breakdown. I think that you did in a very nice flow of thoughts to kind of lead us into how we're thinking about hypothermia and a deeper understanding also just simply that the patient is cold, which I think is vital in the EM setting or any setting, considering that if we are the first point of contact for these patients, that this further understanding and breakdown that you've given us helps us to manage our patients a little bit beyond just this simple idea of we need to warm them up and think a bit further along. So I really do appreciate that. And it's a very well put together presentation as well.
Hi, this is Tammy. I just wanted to touch a little bit more on the rewarming techniques. We've got particularly passive rewarming techniques all the way to active, and there are on a spectrum. It will depend on the severity of the hypothermia and your availability of resources as to which techniques that you are going to use. So the passive external techniques are very typical, the ones that you would use if you went on a camping trip and somebody was suffering sort of from mild hypothermia. Our active external techniques include low-tech techniques as well as medium to high-tech techniques where you are applying heat to the outside of the patient to warm them up. Active internal techniques involve both humidified warmed gases and endovascular IV fluids or warmed blood and blood products, all the way to the invasive techniques, so abdominal irrigation with bladder, gastric, and peritoneal lavage, and then pleural lavage as the other option. And then the extracorporeal stuff, and I'll show you guys some cool pictures now. So where I work, we've got easy access to a forced air warmer, the Behaga, although we only have one. We do have one in our department. Remember, they do come with their own specialized blankets that prevents the patient from burning. And then a radiant infant warmer. This is obviously more common in the pediatric environment, but some of your EDs also might have it. Just to know that the forced air warmer very well might have an over blanket, so we're used to that in the emergency department, not just used in medical science but also in veterinary science as well. Under blankets also do come with the forced air warmer devices to be used in ICU and theatre environments. So Criticool and Arctic Sun, those are two very fancy targeted temperature machines. We used to have the Arctic Sun in the Helen Joseph ED. Critical, commonly found in our ICUs, the one pictured here is a Critical Mini, so being used for little children. These devices are commonly used for targeted temperature management in post-cardiac arrest care, but are very good at doing controlled temperature increases and controlled temperature decreases. So great for using for our hypothermic patients. If you're in an ICU environment or working in a pre-hospital ICU environment, you might come across the dialysis machine or your portable ECMO, depending on your environment.
So let's say you have a hypothermic patient, say a 6-year-old in the ED. They do have a pulse, but they have severe hypothermia, and it's maybe the ED is incredibly busy. You have limited resources, and as Kelsey's asked someone else on the floor, like, we can always put an NG2 and do a gastric lavage for this patient. What would you think would be the recommendations?
I'm just gonna hazard a guess, but I think it would be very difficult to do practically. I mean, like, I think aspiration and things like that in our setting would be very high risk. Even if they do have a pulse, the kids they'd likely be like lethargic, and the airways are likely to be like threatening, if not already threatened. So I just wouldn't know. I wouldn't know practically if I'd be able, like, if I could consider it. I probably wouldn't consider it.
Yeah, I think that's exactly, you pointed up all the important things. I think whenever you're deciding on an intervention to give a patient, what we always need to think about is a risk versus benefit ratio. And the risks of using gastric lavage, because it is a means of supplying some degree of a warm fluid to the body internally that will obviously heat the patient up to some degree, but the risks that come with that, the risks of, like you mentioned, aspiration, the airway protection, you don't know what their GCS is going to be, the fluid shifts and electrolyte shifts that you might induce in these patients outweigh the benefits when we have other methods and mechanisms in place to heat our patients.
This is the last comment from me. Much like all things in emergency medicine, you'll find many guidelines and many algorithms. This is the one that was released by the ERC in 2021. You'll see there's quite a big focus on ECMO CPR and getting access to ECMO for accidental hypothermia. Obviously, in Europe, they do have avalanches and skiing accidents and severe hypothermia because of our environmental exposure. But it's still a really cool algorithm, and it's nice to have a look at.
I think what's important to remember in this, and which Marthinus brought up really nicely as well, is this idea that we get this active and passive rewarming. And it's very important to distinguish between the two, simply because passive rewarming relies on the patient's ability to actually induce that metabolic increase in demand and rewarm themselves. And it's usually more appropriate in your settings of the mild hypothermia that Marthinus spoke about. Obviously, if the patient has any impaired metabolic function, or like potentially they have a thalamic stroke or something like that, that this passive warming might not actually be as effective as we'd like it to. And in those cases, to recognize that we do need to initiate this active rewarming. And it's quite a process, and there's quite a lot of effort that goes into actively rewarming a patient, and it's not something that can happen quickly.